Hi everybody. Right, it's been a long break since we have had a discussion on our channel. I think today I would like to discuss a presentation that I would like to make on how to improve your laparoscopic skills quickly. So my name is Dr. Yamal Patel. I'm a consultant obstetrician and gynecologist based here at the Third Park Hospital in Nairobi, Kenya. And I am an advanced laparoscopic surgeon and an endometriosis surgeon. So, how do we improve our laparoscopic skills quickly? So, the objectives today would be, one is we'll have an introduction to what is involved in the training in minimal invasive surgery or laparoscopy. What is an ideal learning curve? We'll talk something about the 20-hour rule, and then we'll discuss on how do we have some shortcuts to a quick learning. So, it has been said by Lao Tzu that if I hear, I forget. If I see, I remember. But if I do, I understand. And in the last 50 years, the mankind's most profound advancements have been in biomedicine and computer science. Now, in MIS, these are converging. So, education is the key concept that we need to tackle to get these two together. Who are the students of medicine in MIS? We could start right from the medical students to the residents in training in the specialty of obs and gynae, to practicing doctors and surgeons, nursing students as well, and to practicing nurses as well. So it's the whole range, because MIS or laparoscopy is actually a teamwork profession. So in the past, when we learnt about medical education, we had the dictum see one, do one, teach one. This rule may not apply to minimally excessive surgery or minimally invasive surgery, which usually has a long learning curve. The complication rate has been found to drop from almost 13 to 15% to 3% after the first 100 cases have been done by a surgeon. So how can we overcome this steep learning curve, long learning curve, and try to get the skills and effective work quickly and safely? So let's take an analogy of the real life situations. Let's assume we take a flight, a 747 flight to Dubai, and the pilot before takeoff announces, "Dear folks, our co-pilot today has never had the opportunity to land solo before. We'll be practicing one shortly, and we wish him all the best. I'll be joining you in the cabin shortly as he lands." Imagine the situation of panic that would create. Imagine a squadron commander during an Operation Desert Storm in war tells his troops on the eve of the battle, "While none of you have fought under these conditions, I hope you'll figure out what to do tomorrow. All the best, guys." I mean, you see this analogy, and I don't think this is something that you would hear these two professions do. So they would train them, they would have them undergo drills, they would have them undergo the basic skills required for this, and then proceed. So why should medicine and MIS be any different? So in training, what is available? We have literature, we have videos, we have internet, we have the YouTube these days that has a lot of learning videos about MIS training. We have computer simulation. We have case observation. We've had laparoscopy courses and workshops. We have surgeon mentoring, and we have fellowships training as well. So we have a whole range of training available. What is an ideal learning curve? In MIS, it is long and graded. It will start from the dry lab training to structured instructional courses, to animal model skills acquisition courses, to assisting in surgery, to surgery now being done by you under supervision, to self-surgery in properly selected cases with a review by a mentor, and then you graduate to a full MIS specialty. So that is the course or the normal learning curve. We do have mechanical trainers, what we call the endo trainers, and these are usually very good for training hand-eye coordination. Camera skills can be trained in it. How to adapt to 2D vision when operating, because when we are doing open surgery, we are doing 3D vision surgery. How to get the depth perception into perspective. How to understand reduced feedback or haptic feedback, which means how do we know when we touch this? It's not the same. When you hold this with your hands closed, and then you can feel it, and your haptic feedback tells you this is a rectangular structure that is hard, and that is probably something like a hard drive. But now imagine you doing this with laparoscopy, where you're trying to figure out what this structure could be, and you don't know whether it is hard, you don't know whether it is soft, so you have to learn skill. Then trocar placement, you have to know how to place these so that you have adequate ergonomics, because ergonomics is one of the things that can really mess up MIS careers for many patients, many doctors, because it is not going to allow you to have a long career in MIS if you don't follow ergonomic principles. And then also to learn fulcrum effect, that in open surgery, if I want to move this from here to here, I push it across. So that's translational movement. Whereas in laparoscopy, if I want to move this up, because there is a fulcrum here, I have to move my hand down, and then this moves up. When I move my hand up, that moves down. So you have to understand and practice this, because this is something that will come only with training. The next level of training that gives a little different feel would be hybrid trainers. So these are like mechanical trainers, but they receive input and feedback from a computer, and it assesses you at the end of it. Then we have virtual reality or simulators or trainers, which actually manipulate the images and receive feedback, and it actually has sometimes pre-programmed procedures set that actually you will move your instruments to, and it will assess how you're doing. The next level of training would be mentoring as well. So another type of training is mentoring, from a mentor to a mentee. Now, it requires commitment from both the trainee and the mentor, where you will have didactic lectures and instructional courses with the mentor, a one-on-one interaction, theater assistance with the mentor. Then we have videotape mentoring, which is critiquing and analysis of a surgery after it's been done. So sit down with your mentor and go through the steps and understand what was right, what was wrong, and how you could do it better. Then review the initial few cases done by the trainee with the mentor. So the mentor sits down with the trainee to see what and how their movements were. And then finally, review by the trainee himself to identify his pitfalls and troubleshoot and improve on them. So the trainee is supposed to review his or her own videos of surgery and actually report back to the mentor on how or where he feels he needs improvement. We also have what is something called mutual mentoring. So this is those performing some procedures or practice jointly. So it benefits two novices or early stage surgeons at the same time when you work together, because one is observing the other and you work together. It's one of the best ways to grow your MIS skill. And the advantage here is you get expert camera assistance as well, and a second opinion also during the surgery while it is being done. After this, what is the mentored, supervised clinical training in theater? Well, initially you have your mentee come in as a camera person and explore anatomy, ergonomics, anticipate the steps of procedure being done. So I usually tell my assistant that, listen, the day your movements and your understanding of my movements is more than 70-80% correlated, you're ready to undertake that procedure yourself. So very important that they foresee the next step of the surgeon. And then the next step after in this supervised clinical training would be to have the trainee do part of the surgery and the mentor do part of the surgery, so that you are doing it with the mentee together. We also have something, next step would be near presence telementoring. Near presence mentoring, sorry. So near presence mentoring means that the mentee does the surgery, and the mentor is around the theater, walking and seeing what the mentee is doing, and basically trying to guide them. No, go left, okay, slightly there, okay, now you're right, that's the right plane, dissect further, there's a bleeder there, use bipolar, and let's see. So they are guiding, and each step is having a supervised view from the mentor. Yeah, it's good, it helps, but there is increased performance anxiety that is noted in this approach by the mentee, because they know someone is watching me and is actually overseeing what I'm doing. So there is a confidence, yes, but there is also anxiety. And then there is telepresence mentoring. Telepresence mentoring means that the surgery is being done by your mentee somewhere, and you are on a phone call. Should he need or she need any assistance? And in this situation, if they are stuck somewhere, they would call, and nowadays you can easily do a video call, show you the video segment as it's being done, and now you can guide them. So the benefit is you can get an intra-op advice. It allays the performance anxiety that happens when the mentor is in constant presence in the theater. It assists independent decision making, but knows that there is professional advice in the background should I need it. And it increases confidence because expert hand is not far if needed. So, there is something called the 20-hour rule that has been described earlier. And we want to learn how to be good at something very quickly. So really good at something quickly, you may need the 20-hour rule. So this is a video, for example, of a surgery, courtesy YouTube from a doctor called Dr. Tomonori Hada. And it's just showing you, I want to show this just to show the proficiency of suturing that someone can achieve with practice. So this is the level of confidence and the level of skill that someone would want to do it. Now it's important to look at this video and see how good someone could get if they constantly pay attention to the minute details and constantly practice. So we want to discuss something called the 20-hour rule. So if we move on further, so we go on to the next step. So there was something that has been there for ages, and that's the 10,000 hour rule. The 10,000 hour rule is how to get your proficiency, and you can use this in the aviation industry, and you'll see that they actually capture how many hours they fly before they are given to the next level, and someone's experience is gauged on how many hours have you flown. Oh, I've done 6,000 hours, or I've done 21,000 hours. So you can gauge somebody's experience and say, oh wow, this guy must be really good. So that is there, but is it necessarily true or practical in every situation? Maybe not, because this is 416 days of practice constantly. Is it really applicable to our need? By that time the surgeon would probably be 5-10 years into his career. And if we say he's still not an expert, then that's not something that's acceptable. So, the 5 steps to the 20-hour rule. Number 1, first, establish what exactly you want, your goal. Number 2, deconstruct the skill. Now, most things are bundles of many fine steps, which are the finer, smaller steps of the skill that you need to learn. So don't look at it as an overall procedure. Look at it as fine steps. So research has found that you first need to identify the most important sub-skills required. And you could do that from research and identify the most important sub-skill from books, videos, DVD, trainers, counseling, etc. So go through many books, etc., but don't go through page to page. Skim through them and find things that are repeated over and over. Now, these specific things that are repeated over and over by this person, by this book, by this video, by this, are the specific things that you need to know. So these are the 5 steps. We've done number 1, get your goal. Number 2, deconstruct the skill. Number 3, do your research. Number 4, remove barriers from practice, to your practice. So number 1, when you're practicing or when you're actually practicing your skill to get better at it, practice undivided and focused. Avoid distractions at the time. Turn off the TV, block the internet, close the door, switch off your phone or put it on silent, etc. And then practice. If you're going to practice and every second minute or there's a TV going on and you're watching and practicing, or every second minute there's a phone call ringing, then it actually disturbs your concentration and you will take longer to get that skill. And finally, commit to 20 hours of focused practice before you begin. All right? So you can say you will time yourself. I'm going to do 15 minutes of endo training with my suturing skill. And those 15 minutes are logged as 15 minutes. And it should be focused, it should be uninterrupted, and it should be knowing what skill am I trying to achieve in these 15 minutes. So in these 15 minutes, I've broken my skill down of suturing, lap suturing, into I want to load the needle. And you actually only learn to load the needle because suturing is not just suturing, and that's the mistake people do. So they think they have to put the needle in and go and start, and they want to do start to end, and then they get frustrated. So the best way to learn is break it up. First, learn how to introduce the needle and remove the needle. Introduce the needle, remove the needle, different techniques, and practice that. Then, next, learn how to load the needle. So loading and releasing, loading and releasing, loading, setting and releasing, loading, setting and releasing. So this is the next step. Then you learn how to pass it through the tissue and remove. Pass it through the tissue, wrist movement only, pass it through the tissue, remove, pass it through the tissue, remove. So do that many times and get proficient at that. Then the next thing would be now make a knot and make a secure knot that you are. So if you do it this way, you learn better than wanting to do it at one go. So what are the shortcuts to a quicker learning in MIS? There's something called gaze training has been practiced, video games have been suggested. So is PlayStation really a good way of learning your skills at movement? Maybe. That's why you might see very younger generations, surgeons now being very good because they're very good at PlayStation as well. Well, I didn't learn the PlayStation way, but that's definitely a way to go. What is gaze training? So gaze training means they've actually done studies where they put in VR and then the surgeon, the surgeon's view was put on the VR for the assistant. So the assistant was not seeing the screen directly, the assistant was seeing what the surgeon was seeing. And they actually realized that actually the learning curve was much faster when the assistant was shown what the surgeon was seeing, meaning where his gaze was going all the time, than when he's seeing a screen and the mentee is seeing his screen and they are seeing different locations. The surgeon is focusing on His gaze is on actually a vessel, but the assistant is seeing something else. So if we make them see the same thing following gaze training, the learning curve shot up very quickly. Then start with achievable goals. Don't keep very high goals initially. Be happy with being able to put in ports first. Be happy with being able to hold and grasp and do traction. Be happy with able to dissect and cut with scissors. Then move to the next step. Be happy with able to suture. All right? So if you move these steps upwards, then it's easier. And finally, start early in med school and not in residency. So let's start training these young doctors, budding doctors who are still in med school while they're training for their basic medicine course, and then bring them up to the next level while they're doing their residency. Don't start too late. It might be more difficult to train them into it than when they start early. Bring in simulators in med school and start it. Confident driving. I mean, you will see that when you are confident in driving, you actually start being confident in this. And start training people to be ambidextrous. So this idea of I'm a left-handed surgeon or I am a right-handed surgeon is fine. I mean, that's your dominant hand, but that doesn't mean you should not be able to use the other hand completely. Train to be ambidextrous. So, mandatory participation in training sessions and having supervised personnel, encouraging healthy competition among these trainees as we are doing it, keeping a log of all the training sessions and progress is important. And finally, practice, practice, practice. Never give up. So, it is said, a person who never makes a mistake never tried anything new, by Albert Einstein. And therefore, please don't be afraid of making mistakes. You will learn from your mistakes, and it's better if you can learn from others' mistakes, but practice and then it will become better. So this bridge between accomplishment and your goal is actually discipline. So be disciplined, and with this you can definitely do it. Never stop learning. Practice, 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 and you'll get better faster with only 20 hours of dedicated MIS training. Thank you.